Okay, so we're recording. So yeah, this is a bit of an exciting opportunity for Laura and I to come together. It's based, I guess this space was formed because there felt like there was some anxieties and apprehensions around um, personalized care and the defensive medicine around that. And when we did the personalized care training in Mars, there were some concerns around how essentially the concept of litigation and defensive medicine was shifting a little bit in regards to the importance of integrating personalized care in practice. So following that, we recognize that kind of coming into the community appointment days, there are some apprehensions and excitements around how does litigation and defensive medicine be held in a unique situation like the CAD. So we thought it was a good opportunity to come together to discuss some thoughts that Laura and I had around that and ways forwards around that. Do you say, Laura, did you want to add anything to that intro?
I guess, you know, what we hear, and this is not unique to this service, but what we hear is that there is a sort of a worry about missing serious pathology, and then, you know, what are the consequences if you do miss serious pathology? And I think, you know, if we do nothing else, we'll try and answer that question today, really, around, you know, how that can play out.
Yeah. Okay. Perfect. So let's get it going on. Right, so I'm hoping that you can all see that slideshow.
Yeah, can see it, but just, yeah, perfect.
Yeah.
Yep.
Okay, so we thought I had these great ideas of how, or I really liked the idea of how personalized care meets defensive medicine in like a boxing ring. You've got one corner that's like personalized care. It's all about NHS long-term plans, shared decision making, you know, better patient outcomes if the person's involved in their care and their story, informed choice, all of that in one corner of the ring. And then you've got defensive medicine, which is all about that litigation, insurance companies, public expectation in the other corner. And you kind of think, who's going to win if these two battle it out? So Laura and I are going to sort of try and take you on that little bit of that battle or that story together. And maybe one day we'll actually be able to get in the ring, Laura, and we can battle it out.
Good luck.
Okay, so we thought it all sort of really stems from what is it? What is it about defensive medicine? What drives it? And Laura's going to go into this in a bit more detail on the next slide, but it felt like it really sieved down to how we carry this sense of fear. And the beauty of that is that we all share this sense of fear. So it comes from a good place in a way that we want to do no harm. You know, we've grown up good people not wanting to do harm to anybody or anyone, and then through our professional practice we've kind of had that ingrained in us of like, do no harm, whatever you do no harm. So we want to protect that and protect others. So kind of this defensive behavior is centered around that partly. The processes, we kind of reflected on how processes can hinder the way. And just a good example of this, which I know a lot of you will kind of relate to, is, you know, the FCP template, for instance. In order to save that template, you have to tick that you've talked about red flags. And in some instances, maybe it's not appropriate that you brought that up, but you have to tick that in order to save the template. And if you're anything like me, I carry a lot of guilt. I'm like, oh no, I've ticked that box, but I haven't gone over the red flags. So should I go over the red flags just to tick the box? You know, so there's this internal dialogue of how some processes can hinder us doing the right thing to really truly reason it correctly. You know, and sometimes accessibility to information. So if the person isn't necessarily aware of how they can get information quickly again, that can hinder the process of supporting people to be involved in their journey, which you kind of could reflect on as we go through this presentation. Serious pathology does masquerade as MSK conditions. So it's part of a process, it is part of the story, and it is a potential possible reality. That is something we have to accept. But it's also a moment in time that we have with a person in their journey at a particular time. So how can we try and expand upon that moment, that the person carries that moment in time for further along their journey, so we don't take all the burden that we have to do everything in that moment, when actually it might not be the right place and the right time for us to explore serious pathology for that, with that particular person. And this falls into this idea that it's a conversation, and a conversation that we need to have with that person that carries on within their life for life. And Laura, you had a great example of how, when you were a junior and you were working with somebody with mechanical lower back pain.
Yeah. So, and yeah, just to reiterate, really, I think, it can be really challenging. We know serious pathology is challenging. It can manifest itself really well in the late stages, and by then it's often too late. And we know, part of the kind of my push within serious pathology is to pick it up early, is to try and capture these patients early, because for obvious reasons they do better if we do that. But we know it's challenging. It's not easy to identify. It's picking up those subtle cues and watching how someone can play out over time is really helpful, because that's what happens with some of these cases. But Georgie we were talking earlier about the kind of cases where you are going to miss these things, because that's just the nature of the beast. And as Georgie said, when I was a junior, I was working, I did some private work at the hospital, and I had this guy who came to me with mechanical back pain, nothing else, absolutely nothing else. And at that time, this is how long ago it was, we were still doing traction, and he was responding really well to traction. I did some mobilizations, exercise, doing really well. He came for 3 or 4 sessions, and then he stopped coming. And of course, I thought, oh, it must be better then, must be all right. Great. He came back to me about 3 months later just to have a chat. And he said, just to let you know, I ended up having back surgery because I had an ependymoma. So he had a tumor, primary tumor in his spine. But there was no indication that was going on for him at that time when I saw him. He had no other symptoms that were suggestive of that. So, these things happen. They can happen. That's just how it can be.
Yeah. Yeah, we put a lot on ourselves, don't we, to just know it all then. And
Yeah,
you
and
can't.
you can't. You just can't. You have to kind of deal with what you've got, and the questions you're asking that individual. And I think it's, there is a balance, isn't there? What we're trying to do is we're trying to kind of capture those things as quickly as we can, but without responding in such a way that actually is harmful for the patient. So what I mean by that is, let's say you've got a patient who does have a past history of cancer, happens to be breast cancer and back pain. It's not enough to act on. If we did that, we'd probably blow the system up. But essentially, there's anxiety around, well, what if they've got cancer? Well, they might not have. Majority of them won't have cancer. There'll be a small number that might, and actually it's about the context that that patient's coming to you in. And they might well come to you with nothing going on, just maybe a couple of risk factors. There's no other indication, but maybe months or even weeks later, they start to develop those things. It's not that you've missed it, you've thought about it, you've wondered whether that's the case, you've done a differential diagnosis, and at that moment in time, there was no indication of that was the issue. It's just how it can play out and evolve over time. And that's what's really important here is that often these things can look very benign and stay pretty benign for a period of time. Then suddenly they start to develop, and it's our ability to be able to monitor that change that's really important here.
And that's what you really lent into before, hey, Laura, about the passport and kind of that very clear section that when people check out of the community appointment day, we're going to really encourage that reflection of if things get worse or if things change. And this is part of the conversation, leaning into that individual to hold some accountability and responsibility of if things do change, what to do, and knowing that they have a plan, some next steps of what to do. And the passport will support that.
Yeah, no, absolutely. And I think, this is about making sure that, people know that they can come back if things change or they get worse, and it's a very broad brush kind of safety netting approach. But it's sometimes that's enough. What we want people to understand is that many of our musculoskeletal conditions, they play out. They have a natural history. They get better. We expect them to do this and this, and therefore patients should expect that to happen. And if they don't happen, then they know what to do if something's worrying them or they're concerned about it. That's what we need them to help us with. I can't look after that patient 24/7 to see how that's going to manifest itself over that time.
Yeah. And working in FCP, I know those people that do work in FCP, they'll have seen this sort of behaviour more within the GP world, where this watch and wait, there are some subtleties here that maybe are concerning me, or I'm holding very gently. I need you to be aware of them, and if they change, to come back. And the GPs lean on that all the time, don't they? Which
They're
we
very good
as
at it. Yeah.
physios, osteos, podiatrists aren't so comfortable leaning into that, because there's so much uncertainty around it.
And I think in most cases, and you can exclude cord equina syndrome and known metastatic spinal cord compression, but if you look at most other sort of serious pathologies, patients do not come to harm if we wait a while to see how these things play out. That's highly acceptable, really. Because then you're not rushing that decision about, I think they need a scan or they need more investigations. We kind of just need to see, well, what's going to happen next, to see whether we do need to make that decision or not. And that's okay. That's highly reasonable to do that.
Yeah. And then there was this other point, hey, that we fear feeling like failure.
Yeah.
And
Yeah.
fear other people judging our competency. What if somebody picks up these notes and they think, oh no, I missed it, or I didn't question the right things at the right time, and or I didn't pitch it right. And I think that's such, that's such a blame culture, isn't it, that we sit within. And I really hope working within this service, people feel like that we're easing away from blaming people and supporting that open mindset of learning, establishing understanding together, and developing that.
And I think you're hitting on something really interesting. I think sometimes what we hear is, well, if I've missed something, the organisation won't support me, and I'm curious about where that comes from, because I don't believe that is the case at all. I don't think there's been any cases where we've pointed any fingers at anyone. I think this is about learning from these cases. We're not always going to get it right, and sometimes it's just, they are so complex that they're difficult to pick up on. And hindsight is an amazing thing. You can look back at something and go, well, why did they miss that? But there are lots of reasons why things might not have been picked up, and there's huge nuances with some of these things. And I think Georgie's right. We cannot sit in this sort of a blame culture, which the NHS is very good at, actually. And then you become sort of very defensive about the way you've done things. But actually what's required is for us to learn from them, to learn from our mistakes, or to learn from those kind of cases where things haven't gotten quite right. That's where the rich learning occurs. We can talk about the ones that have gone well, but that doesn't give us the learning. The learning comes from the ones where we just haven't quite got this right, and where we can do better. And to be able to do that in a really supportive way, where you're able to share those stories.
And it's almost like when you next act around sort of serious pathology, or it's questioning what's driving this behavior. Is it because I've got some real clear objective signs that are so certain and I need to kind of safety net, or lean into kind of this, or is it fear of not doing something, and fear of like then being blamed or being judged or getting it wrong or creating harm? It's just maybe having a little pause and a moment in time. And I think maybe if you're unsure, it's knocking on the person's door, isn't it? Or leaning into somebody else that can help you work out, am I behaving out of fear on this one? Or have I got enough here to be fearful or to be concerned? And how can I share that?
Absolutely, and I think, you know,
Mm.
one of the things that's helped me probably over the years is to have that sort of support network, to be able to tap into people and, you know, really kind of, you know, get people to help you kind of work it through. You know, sometimes just
Yeah.
by voicing it is enough to then realize, okay, yeah, this is why I'm feeling like I'm feeling. You know, so, and there's often, you know, there's often a reason why you're feeling like you're feeling, as Georgie says it, and I think, you know, by rule of thumb, I would say if you're taking your patients home with you, then I would just sit up and think, why am I doing that? Because there'll be a reason why you're doing it, and then it's really important to kind of look back and see why you think something, and then
Oh,
speak, you know, talk it through.
and I just, as you're talking, I'm just thinking, oh, what a great opportunity the community appointment day will be to share those fears if they
Yeah.
come up, and to share this feeling of, oh, I'm thinking about this. What are your thoughts? And
Mm.
the what matters to you conversation will really explore the fears of the individual, the concerns of that individual. And if our own fears and concerns come up, we've got a wealth of people to share them with, in
Yeah.
regards not just the person opposite us, the patient, but a wealth of knowledge, clinicians of all
Yeah.
different shapes and sizes, which just
And
feels so
and I,
good.
I and what a great opportunity, as you said, because
Yeah,
I think, you know, in our current system where we're working behind a closed door, or,
yeah.
you know, we're you know, we've got pressure of time, it's very difficult to step out and to find
Mm,
someone who's got the time as well to do that. And I think this would be a great opportunity to do that.
yeah.
Really nice.
Okay, so moving on to something, Laura, you've spent so much time pulling together, and I guess it links into what we kind of just talked about, hey, in regards
Mm.
to like the past experience and experience of others, and the pressures that lead maybe defensive medicine to become a
Yeah.
bigger thing in our world than we want it to be. I don't know. Do you
Yeah.
want to feel okay to
Yeah.
talk about this?
Sure. I mean, I guess I wrote a paper around defensive medicine, or defensive practice, because I recognise that actually that was there was a potential for that to be going on to some extent, because of pressures and uncertainty around, particularly around serious pathology. You know, this worry about missing things, and I guess it's very well documented within our medical colleagues, really well documented, but not so in physiotherapy. And so I guess it was a way of trying to say, well, you know, we really want to try and avoid stepping into that kind of area if we can help it, to be fair. And when we talk about defensive medicine, what we're talking about is that where we over investigate individuals, or we um, do too much clinical activity when it's really not necessary. We invite them back for over and over again for further appointments, or these unnecessary investigations that actually offer no value to the patient at all. And what happens is that you know, the benefit is not for our patients, the benefit is for us as individuals. It gives us that kind of reassurance, and actually what you end up doing is really not clinically reasoning through why you're doing the things you're doing. You're just doing it because you're concerned for yourself, and you're worried about litigation, etc. And there are lots of reasons why this can happen, and this picture tells you, really, you know, there's this degree of uncertainty that can drive it massively. You don't know what's going on, things are not really clear. So you go on a fishing expedition to see, you know, well, I've done a scan, but it doesn't show anything, so let me scan somewhere else. So okay, that doesn't show anything, so I'll do something else, because you're just not clear about it, and you want to have that sort of certainty. We know that patients are driving some of this defensive practice. You know, patients are coming in, you know, demanding for that MRI scan, and you know, it's about trying to get them to understand why we do those things and why we don't. You know, some of that past experience and experience of others can drive it. You know, certainly I was involved in a litigation case many years ago, but can remember it very clearly. And my experience of that litigation made me scan more people than I should have following the event, because of that experience. Eventually it settled down, but you know, just something like that can really sort of drive some of your processes and thinking. You know, pressure in the system, you know, just how the way we work, the systems we're in can really drive some of that defensive practice. And time pressure. If you've not got time to think through and reflect on what really is going on here, sending someone for a scan buys you time. And that again is inappropriate, but can happen just because of the way the system is. So there are lots of things that are going to drive this defensive medicine, but it's really not at the benefit of our patients. If anything, it can drive inappropriate investigations that can cause harm to our patients. And in some cases, we know that it can drive unnecessary surgical interventions. So we want to try and avoid that, because you stop thinking, you stop clinically reasoning through why you're doing something. Do you want to add anything, Georgie?
Yeah, no, I think you've just this amazing summary. It's really, I think as I'm hearing you talk, it just feels so heavy. It feels so heavy on the clinician to hold all of this. It's a big mental load, and I think we share that feeling that it's just not sustainable, and we just the resilience around, how do you build resilience around this? And I feel like we're going to lean into that a little bit now, aren't we? Because just moving into what we all know so well, the biopsychosocial model, which is how we've worked, essentially where we've been trying to work since 1977, 36 years we've been trying to work within this model. But I think the reality, the health service doesn't really reflect this even perspective of maybe how we look at people. And this is maybe where the defensive medicine has really been brought into play so much, because it really, in a way, looks like this, doesn't it? Like defensive medicine feels like it really sits within the bio of the biopsychosocial. So it doesn't really fit within the social or the psycho, does it? It really can't.
No.
And I guess we chatted about how, if you're the biomedical can feel a little bit more certain, falsely so. And it gives us, maybe if you see it, then it's easier to believe, isn't it? If I kind of, it's quite positivist, objectivist,
And it's pretty linear, isn't it? That's the problem. And we talk about the psychosocial model as being the model that we all adhere to, but the reality is we don't. It would be good if we did, but we don't. And I think it's because the biomedical model really is a model that really gives you some certainty, and so it's about kind of that pattern recognition. It's knowing that you've seen someone with this particular presentation, go, I've seen that before, so it must be this, and therefore and I've treated them like this. I'm going to make it fit. I've treated the patient like this, so yes, that must work. And of course it doesn't always play out like that. And I think, but it's a structured way of looking at something. And when I started a physio, I had a very structured examination, because that was the way I learned, and it helped me kind of process things. But it just isn't quite as clear as that. But that's what we do. We assess the patient, we investigate them, we do some tests, we come up with a diagnosis, and then we come up with a management plan, and it's all packaged up really nicely. I know what I'm doing, the patient knows what I'm doing, and boom, what's not to like about that? It just doesn't account for all the other elements that we know make up that patient sort of presentation and story that could be missed really easily if we don't go down that route.
And people, Laura, were really reaching for sort of examples. And I know you've got an amazing example of a GP that's sort of really experienced being fit into a box by a medical box. And I wonder if you could talk about how, like, this guy Stephen really felt very stuck in the biomedical model, and then all the clinicians that he saw were really stuck in the biomedical model until it was like, oh, actually this doesn't actually fit.
No, and it's a really interesting story, and there is a podcast to this which I did with him quite a few years ago now, but he was really keen that his story was shared, because he didn't want anyone else to experience this. But kind of when I sort of looked at it more recently, I realized that, how biomedically modeled this whole thing. So it is an interesting story. He was a 33-year-old with basically diagnosed with an osteosarcoma. And when I go through the story, you'll probably think, oh, I would never. Why didn't the clinician say something, or why didn't the Stephen say something? But these things happen, and I guess it's a bit of an invitation to say just hear it, and then we can discuss some of those nuances, I think. But he was a 33-year-old, very fit, was going to the gym regularly, training quite a lot. He took his health really seriously. He had started to develop some knee pain, but he didn't think a lot of it because actually he's had knee pain in the past. He had about 2 years ago in the same knee, got better. And so he thought, well, I'll just see how it plays out. I can treat it. He'd attended a couple of our AP clinics, so he felt he had enough information to manage that. So he kind of treated it. But it wasn't really getting any better. He started to notice his pain was becoming more constant. And so he decided, right, I'm going on holiday for 2 weeks. I'm just going to do nothing and rest. I'm not going to go to the gym, and we'll see how it goes. But he comes back from holiday. It's not any better. In fact, he feels it's more constant. So he decides to get some intervention. So he goes and sees a physiotherapist. And the physiotherapist takes a look at his knee, and he basically assesses him, does some tests, comes up with a diagnosis of anterior knee pain, and puts him on a management plan for that. Now, during his time that he's with this physiotherapist, things start to change. There are two things that predominantly happen, or two things that are of note. One was that when the clinician pressed on Stephen's knee above the knee, his kneecap, Stephen almost kind of leaps through the roof because it's so painful, and the clinician's kind of a bit sort of, oh, that's a bit strange, but doesn't say anything, just puts in his notes. I'm not really clear about what's causing the pain above his knee, and sort of question mark. And the second thing that happens is that Stephen starts to develop this intermittent limp. Just suddenly he's walking, he starts to limp, and it's a bit odd. So he raises it with the clinician, and the clinician sort of has a look at him, and he essentially says, well, I think it's because you've got weak glutes, and therefore that's making you limp because of the pain in the knee. So we just need to strengthen them up. So he could really kind of put something on it and just say, yeah, I think that's the core. So we'll treat that. Now Stephen's kind of thinking, this just doesn't all tie up. He says, I just feel like it wasn't a barn door anterior knee pain. In his experience, he just felt it wasn't barn door. And so neither Stephen tells the clinician this, and the clinician doesn't tell Stephen, I'm not sure what's causing some of these other things. So what happens is Stephen goes and seeks a second opinion. He goes and sees a orthopedic consultant because he wants to have someone tell him what's wrong with him. I want them to tell me exactly what's going on, what's wrong, and to tell me what I need to do to fix it. So by the time he goes to see the orthopedic surgeon, he's now got this constant limp, and he's starting to get some sort of disturbance at night time, and he's also got some wasting around the knee. So he sees the consultant, and the consultant assesses him. He does some tests. He gives him a diagnosis of anterior knee pain, and puts him on a management plan. And that management plan is to go and see a podiatrist and go and see have some more physiotherapy. So he goes to see the podiatrist. The podiatrist has a look, comes up with the same thing, says anterior knee pain, you need some orthotics, carry on. He then goes and sees the next physiotherapist, and by this time he's really got significant pain. His night is really being disturbed, and he's having to take some time off work. And the clinician looks at the orthopedic surgeon's letter, and says, yes, I agree with him. It's anterior knee pain, and we can sort it out. It's not, it's all fine. We'll sort it out. But at this point, Stephen then says, he raises his concern that he thinks he's got an osteosarcoma. But he laughingly goes, haha, I think I've got an osteosarcoma. And the clinician just kind of laughs with him and said, no, of course you haven't. You haven't got a sarcoma. We can sort all of this out, no problem. So he's been treated by the clinician, and he said, she was lovely. I really trusted her. I thought, she's got really all this experience, and everybody's telling me the same thing. They're all saying the same thing. I've raised that I've got this, I think I've got a sarcoma, but everyone's thinking, telling me you've got anterior knee pain. He then has to take some time off work because it's just so bad. He goes back to work, and when he goes back to work, one of his GP colleagues looks at him and says, Stephen, you're not looking so good. Let me have a look at you. So he sort of goes and has a consultation, and she kind of looks at the consultant's letter and says, well, I don't really agree with his diagnosis. Sends him off to have an X-ray. He goes and has the X-ray. He can remember very clearly that when he's had the X-ray and the radiologist is looking at the X-ray and then looks at him and says, are you having a follow-up? And he knew then, he said, I just knew something was not right. By that afternoon, he's admitted to the hospital, and he's this close to fracturing his femur. And if he'd fractured his femur, he would have lost his leg. So he was lucky not to lose his leg. And so, what you see in that story is this, this person who's a GP who's stuck in that biomedical model. He said, I didn't want to tell the clinician what I thought was going on. I didn't want to be like those patients who come and see me and tell me what they think's going on. But actually, for me, what would have been really nice is that he could have done that. He could have said, this is what I think's going on. I think I've got an osteosarcoma. This doesn't feel like a barn door anterior knee pain. And to raise his concerns and to raise his anxiety, and for that to be heard by the clinicians. But he felt that he could do that. Whereas equally, I'd want the clinician to be able to, say to Stephen, when you jump off the couch like that, when I press your knee, that's not normal. That doesn't fit that anterior knee pain pattern. Let's just have a look and see what's going on there. What else do we need to consider when we get to that point?
Talk to me about your thoughts about it. What are your thoughts? You're a GP with all that wealth of experience of medical knowledge and the concerns. We've kind of forgotten, haven't we? Almost feels like we've forgotten to listen to the concern, or to ask for the concerns of that individual, and to really hear them and unpick them. Because we might, our bias might feel like that concern, like with that the physio, the individual going, no, it's not that, it's not what you think. That's about their bias, isn't it? That's about their understanding, instead of kind of going, oh, well, tell me why you think that.
Yeah, so if if he laughingly said, which he did, haha, I think I've got cancer. Why do you think that? What's making you think that?
Tell me about that.
He might have said, he said, that I'm an anxious person. We've just seen someone with an osteosarcoma, but actually, when you drill down to it, he knows that things aren't right. He's got that experience to be able to say, doesn't feel right. Something's not quite right here.
And the potential litigation around this, Laura, is around sort of not necessarily, the biomedical, not necessarily considering the different, although they were stuck in a biomedical model, there was this feeling of fitting that person into a box. Anterior knee pain, it looks like that. Everyone's saying that it must be that. And so we kind of touched on maybe reaching into that individual, because that individual has their own understandings, and reaching into why have they got their understandings. So not just, oh, I think it's this. It's like, well, why do you think that? Kind of going deeper, but kind of thinking as clinicians around the laterals, the differentials, the weird and wonderfuls. If it doesn't fit a pattern, start questioning a bit sooner. Why is this not fitting? If it's anterior knee pain, I know things can take quite a while to get better.
Yeah, and I think, it's difficult, isn't it? Because he was seen by 5 clinicians, and they all focused on reaching a diagnosis and fitting the symptoms into that diagnosis, as you've just said, and the treatment that he received was what you would expect for anterior knee pain. And in a way, that diagnosis gives the clinician that certainty. That I'm putting my money on that because that's what feels right, and we can sort of ram these people into these boxes, but actually something's just not quite fitting in that box, that you've got to then consider, well, why doesn't it fit? What is it that's making me think it doesn't fit? And exploring that, essentially.
Yeah.
And a classic example of it was easy to pick up in the late stages. The GP got to see this guy when he was not sleeping, off work, limping. He's got some awful, kind of wasting, all of that obvious.
Yeah.
And earlier on it wasn't obvious, but there were some things in there that you just couldn't quite fit into the picture.
Yeah. So it feels like there's something around being really attentive to that individual's own thought process and understanding and life experience and
it's
concerns.
I
And
think it also, sorry, Georgie, I think also just, I get, the other thing is that these clinicians were experienced clinicians.
yeah.
And you're probably thinking, well, I would never have missed that.
Mm.
And I guess, the thing we've got to be thinking about is that you may miss it. But what we're trying to do is give the opportunity to try and think about why again this is a great case to share, because what it pulls out is there are lots of things that could have been done differently that might have made a difference.
Yeah.
It might not, but the point is that there are things that we could do differently.
And people are really leaning into or wanting to know, like, how do we avoid litigations? There's something about thinking widely around the differential. If it doesn't fit, as you would as a prognosis around, if you're going to give something a diagnosis, almost you have an idea of the prognosis around that, if you're doing the right thing and the person's doing the right thing and it is the right thing. So if the prognosis isn't fitting, then it's thinking again and again and trying to kind of decipher that, documenting the differentials and documenting the prognosis, and that you've shared that journey with that individual and you've taken on their concerns. And this was something that we were going to then go into in regards to, we need to sort of shift, don't we? Almost there seems to be a bit of a shift of how we work with the people in front of us, the patients.
Exactly.
And we talked about something that looks a little bit more like this, kind of how we as clinicians and people as patients come together with different life experiences and understandings, and how we share this fear, being prepared to share this feeling of uncertainty, like felt quite a strong theme that you wanted to get, or we wanted to get across. And it feels vulnerable, doesn't it, to share that feeling of, I get what you mean, this is looking a bit different, and I get what you're saying, that this isn't fit in a pattern, you being that medical professional as well, recognizing that you just feel something's wrong. Should we explore that together? We might not get any firm answers, but let's hold this space together, and stepping away from being that expert with all the answers, and feeling comfortable of using that person's experience of being themselves as an expert in the room too.
Yeah, and I often hear that clinicians worry that if they tell a patient that I don't know what's going on here, that actually what that might make the patient think, well, what do you know then? What you're not an expert, and actually that's not my experience. Actually, patients are very grateful when you say, well, I don't know exactly what's going on here, but this is what I do know. I'm pretty clear about this. There's this bit over here that's I'm not quite sure what's going on there, but let's explore that, and let's just put something in place to see how that plays out over time. That's people really appreciate that massively, and I think that's where we need to get to, is to be able to say, not entirely sure here, but this is what we're going to do about it, and we'll manage it. And the other thing that we hear quite a lot is, I don't want to worry the patient. I don't, if I think that they might have cancer, I shouldn't tell them. And again, what comes out really strongly, and in the literature, is that actually when you raise it with someone, say, well, there is a possibility, then actually the patient says, I'm really glad you've raised this, because actually I've been worrying about that. And so they become more engaged in that process, because you're involving them in that conversation that actually they've probably been holding quite to themselves and not thinking that they should bring it up. So
it's like those taboo subjects, isn't it? And I
yeah,
think we can all remember like being held, our parents essentially, or carers holding back from letting us into something that they fear will upset us. And when we find out, it's like, that's really annoying that you didn't involve me, because I could have shared that with you, and I'm completely capable of doing that. So kind of holding that, that awareness of when are we being paternalistic,
yeah.
and we don't need, and almost calling each other gently out on that, or seeing when it shows up and just noticing it. And like you mentioned, Laura, around sort of cancer surveillance, and how there used to be those yearly checkups, and they've sort of like disappeared, almost
Yeah,
leaning into PIFU, like patient initiated follow up, which
exactly.
Joe will be
Yeah.
loving
Yeah,
hearing
lovely to
that.
hear that. Yeah. So, but that's exactly right, isn't it? You could, let's say you had, you've been diagnosed with cancer, and everything's fine, and they say, right, we'll do a surveillance for the next 5 years. So you go once a year. So they might do a scan, they might not, and on that scan there's nothing, and so you wait for the next year. But during that time, something happens, and you start thinking, oh, it doesn't feel quite right, but I'll wait till my checkup because I can wait till then. And of course, by then it's probably too late because things are developing. So, they don't do this anymore, and quite rightly, it's initiated by the patient who is worried or concerned, or has noticed something's changed, and that's much more appropriate
Yeah.
then.
So kind of easing away from these protocols and
Yeah,
strict guidelines, and contextualizing,
yeah,
but involving that person to be able to understand, if things
yeah,
change, if you're concerned, you know how to reach us, and really kind of
yeah,
allowing that sense
yeah.
of agency for that person to hold that,
And
which feels
we
really
do that.
important.
Yeah, and we do that. That's safety netting in the context of,
Mm,
if you look at cord equina, you safety net people who you think might develop cord equina syndrome. You give them a card, you tell them what to look out for, you tell them, what to do if that happens, and what's the route that they need to take. So it's the same. It's about giving them information
mm,
that says, if things change, then we'll do something differently. You come back, or you might be able to give them specifics about what to look out for. It might be, tell me if things change with your symptoms, or notice if things get worse at night time. Things that will help them work out whether they need to do something differently or not.
yeah. Yeah. And like our questions evolve, don't they, with a greater understanding of the person's fears and presentation. Again,
Mm,
not hammering out the red flag questions. If it just isn't, I was reflecting on how with a shoulder pain, you don't necessarily always ask more in-depth questions, but maybe if somebody has second time frozen shoulder, or even first time, and you kind of just go, oh, what's driving this frozen shoulder, you'd then ask more detailed questions around diabetes or thyroid, or
mm,
other stuff that you wouldn't just commonly ask all the time. So we kind of
yep.
really reflected on how, with understanding that person in more detail and what's going on, you'll then bring out different boxes that may be on higher shelves, that you'll
Mm,
be like, oh, I'm going to reach for this box now because it feels more appropriate to get this one out, but I don't bring this out often.
yeah.
So
Yeah.
kind of just, allowing your understanding and growth of questioning to evolve with that person, and
Mm,
sharing that process. um Okay, and we really, it feels like we're really talking about how we're not negating the biopsychosocial model, we're not removing the biomedical, but we're embedding it in this greater sense of communication, the therapeutic alliance, the life world that we bring and that they bring, and kind of functioning more within this.
mm,
And the CAD really supports that, doesn't it? We're really trying to encourage people to think about what matters most to them. Like, come prepared with that. Like, what is most important to you? There's an invitation here to share your understanding, and I'll ask if I can offer my understanding, but what's most important is what you're thinking, and we'll evolve our language and our communication around that.
And you know, it's this move from a consultation to a conversation for me.
Yeah.
You know, and you know, where you can have this sort of joint responsibility.
Yeah.
And as you say, where you recognise the kind of the expertise that each of us bring to that conversation. And I think, you know, that if we do that, then we've got this really powerful collaboration that actually will take care of some of those worries around, you know, missing a serious pathology, or, you know, this moving into this sort of defensive medicine, because actually we're both supporting each other in that space, rather than me taking all that responsibility.
Yeah.
So,
and it's as if this is where the battle kind of the fight between personalized care and defensive medicine kind of ends, because actually it feels like it's about just uniting. It's the sharing of the journey together in that uncertainty, in that vulnerability. You know, personalized care actually enables us to work safely within uncertainty, and we kind of talked about how this is through a sense of being mindful of where we're at, you know, the curiosity, the willingness, the openness that we have to explore with another person, and building this sense of partnership and alliance, and, you know, really putting our ego and our expertise, or like that feeling of I need to be that specialist, and not recognizing that the other person has equal amounts of ability to show an understanding of themselves, kind of, you know, being aware of humility, showing humility, and being comfortable with showing and sharing some vulnerability.
yeah.
Kind of, yeah, we talked about traveling together, so aligning, really leaning into sharing the journey, and being mindful of our bias. You know, what is it that we need? What is it that's driving this? Is it a fear? And the self-awareness of that, and questioning it and supporting it in others to be aware of it. Yeah, I think we come to the end there.
I think we have.
I don't know. It would be really nice to have some questions, wouldn't it?
Yeah. But maybe, you know, and maybe that's what we ask of people who are listening to this. You know, if you've got some questions, pose them, and we'll answer them. You know, it's difficult to do such a broad topic in such a short period of time, but it's, you know, it's an important topic, but it's one where, you know, we need to support each other to go on that journey ourselves in trying to really support patients, particularly if we're concerned about serious pathology. I think, you know, for me, it's about trying not to push the panic button. You know, when there's just one thing that you're thinking, oh, you know, I should be worried, maybe not. You know, just chill about it a little bit and just take your time and speak to somebody and just see how things play out, where you can do that.
Yeah, and feeling excited about the community appointment day, because it offers that ability to work more together and to rely on the support.
Yeah, and I think what the community day will do is also, you know, there are going to be multiple opportunities to check some of those things. You know, what matters conversation might well pull those things out, but actually maybe not, and maybe, you know, it's pulled out somewhere else in the room. But there's multiple times that we can look at it. So, you know, in a way, I think our patients will be well supported, much more than normal in this way.
Yeah,
it would be nice. Be good.
So let us know, give us some feedback if you're watching this and you've got some thoughts. We're really keen, aren't we, to hear them?
Yeah, definitely.
Okay, stopping recording.